And I think this is where the role of antenatal counseling and consultation of the anesthesiologist in the antepartum period when a patient is there, so that she can be counseled for an early epidural, as was pointed out by them.
A patient is on table with a blood pressure of 240, 140 with the fetal distress. How am I to proceed, sir, for the anesthetic management?
Well, I think at this point of time, we need to take measures to acutely bring down the blood pressure with intravenous agents that we talked about, sodium nitroprusside or nitroglycerin infusions. Esmolol can be part of an induction sequence. And at this time, I think you have two lives in consideration. And as we've been repeatedly saying, I think we need to concentrate on the maternal health at this point of time. So I think whatever best we can do, control the blood pressure as quickly as possible and continue your anesthetic also at the same time. I think initiation of antihypertensive intravenous technique of controlling the blood pressure with a general anesthetic. I think that should be the formula to be followed. Anything that Dr. Neeraja might like to add on as far as hypertensive management is concerned?
We are using labetalol actually for bringing down the blood pressure. We are using that. So you start off the IV line, you start the antihypertensives, you try to bring down the blood pressure and then proceed for your anesthesia, what Dr. Ramkumar said.
I would just like to add something there, that at a high blood pressure of 240 by 160, even if the obstetrician says that it is fetal distress, you could still give your initial 2 doses of labetalol, try to bring down that blood pressure. Maybe it's not responsive to your labetalol. Give a spinal, at least some blood pressure will fall down. Don't go in for general anesthesia at this stage. I would rather always prefer to give regional anesthesia.
We have a question here. How do we manage pre-eclamptic or eclamptic patients who are highly irritable even after giving magnesium sulfate for regional or general anesthesia? Maybe the irritable part, the uncooperative patient.
Yeah, I think it's a difficult problem. I think in this situation, maybe, I think depending on how irritable the patient is, if you're not able to position your patient for a regional technique, I think you have to go for a general anesthetic. And these patients obviously will need to be kept in, we'll need to keep them on an endotracheal tube, possibly ventilated, till the irritation may be because of cerebral edema and a possible intracranial problem there. So I think we need to keep them in the high dependency area for some time till the cerebral edema settles.
I think that's fine because you need to give GA to this patient. Don't go in for regional. Anyway, the patient is so restless and these patients especially, they would require an ICU or HDU care later on. So it is better to intubate the patients. You can even add midazolam in case you are, you want to subdue a little more. But I think giving GA would be the best.
If IV line is not available and the patient is having the seizure, is there any alternative route of administration of magnesium sulfate or any alternative product to magnesium sulfate?
The answer to the first one would be, I think if there's no, I guess the obstetric team would be having an intravenous line in place, but I think since I've been pushed to the corner, if I can't get an IV line quick enough, I'll probably go for an intraosseous route. That might be, or intramuscular, but it'll take a longer time to act. Depends on how emergent the condition is. The patient's already throwing a seizure, IM may not be the best option. I think...
No, actually, the obstetricians initially, they used to, use this IM magnesium sulfate. That was the usual thing. You give a bolus and then you give an alternative injection in the buttock. Although I don't say that's the best technique to use. But not having an IV line, if you can't find a peripheral line, at least you can get something in the neck. You can use an IJV or you can use a external jugular vein that is likely to be secured. I don't think so. One will, have that problem that you can't start an IV line.
I think the person who asked the question pushed me to the corner. So if there's no peripheral or neck line available, and I think in that situation, if the person is convulsing, do I get the, yes. I think we have no choice but to go for maybe intramuscular will take a definitely longer time to act. And the second part of the question, I don't know the answer. Is there an alternative drug? What is the alternative drug to magnesium sulfate? You were suggesting, the second part of the question was an alternative drug. I don't have an answer to that. For seizure control. I don't have an answer, possibly.
A temporary control of your seizures could be with your midazolam or IV pentothal. That is the only option left to us. But again, there is no IV line, so I wonder what they would like to do about it.
Alternative to magnesium sulfate, you can use a titrated dose of NTG drip under control. Because what you want ultimately is to reduce the blood pressure. The whole idea of reducing is to blood pressure and irritation of the cerebral tissues. So, when you don't have anything else, you can use the NTG drip also along with the sedatives, you know.
The problem here
But
is
of
they
course
do
it will
not
be a
have
very tricky and it will be absolutely under ECG control.
there is no IV line, remember?
No, I am just telling you, my answer is only to the alternative to the magnesium sulfate.
Well,
not
now
the other.
the consensus is that sodium nitroprusside is considered a better drug, though chances of fetal cyanide toxicity are always there, but then sodium nitroprusside is considered a much better drug as compared to nitroglycerin, considering the maternal tachycardia that could occur with NTGs.
If I may just respond to that, I think there are two problems here. One is the seizure control, and the other is the blood pressure control. So as far as seizure control is concerned, I think Dr. Sunanda has offered the alternative, a thiopentone or a benzodiazepine would control if you have an intravenous access. I think the other thing that you're talking about is a blood pressure control. Again, sodium nitroprusside would have a definitely quicker onset and offset. You'll be able to titrate the drug better. And for a short term, I think sodium nitroprusside is a better option than nitroglycerin, which takes a much longer time to act because of the inherent nature of its, it's a venodilator and an arteriolar dilator, whereas SNP is primarily an arteriolar dilator and it can get blood pressure control much faster. So I think there are two things we're looking at, seizure control and BP control. So I think for seizure control, I think we have to use, as Dr. Sunanda suggested, as far as BP control is concerned, I think we can take your option.
Yes.
Regarding IV access, when you don't have any, fortunately pregnancy is a period of nice peripheral vasodilation. But in the event that you don't have anything else, there is an access available to you, not intraosseous, it's a sublingual vein. It takes a second to stick some midazolam in there. If you've got a patient who's seizing, I realize that a seizing patient may be moving. If you can any kind of get a stability, a sublingual vein is very easy to hit. I've used that in emergencies, it works great.
Dr. Manjushri, you wanted to make a point.
Just small comments. If we do not have IV line, I think intranasal midazolam works very good. The effect we will get within a minute, so you can think about that.
Right. Thank you very much for that excellent talk by all of you. Thanks a lot, and thank you for the organization.